Hello, my name is Natalie Wattam and I'm an acute Admiral nurse at the University Hospitals of Leicester. We're going to be looking today at a patient's journey for the acute Admiral nurses supporting patients from admission to discharge from acute care. And I'm really pleased to be here today as part of Dementia UK Summer School 2023. We're going to be having a look at the transitions in care for the acute Admiral nurse. We're going to be having a look to understand the role of acute Admiral nurse in a large teaching hospital, to understand the patient's journey from admission to discharge, to understand how the acute Admiral nurse can facilitate, influence and support patients and families during an acute admission. We've just got some key words used during the session that will be used in some abbreviations throughout the presentation. If you'd just like to familiarise yourself, we've got UHL, which is University Hospitals of Leicester, the LRI, which is Leicester Royal Infirmary, LLR, Leicester, Leicestershire and Rutland, MAF, which is Meaningful Activity Facilitator, POC, which is Package of Care, Mr. A and Mrs. A as part of the case study to maintain confidentiality, AN for Admiral Nurse, MDT, Multidisciplinary Team, and NICE, which is the National Institute for Health and Care Excellence. First of all, I would like to take focus on the we statements and how this impacts on our care delivery in the acute setting. The person with dementia is at the centre of these statements and they represent everyone living with any type of dementia, regardless of age, stage or severity. And the we used in these statements encompasses people with dementia, their carers, their families and everyone else affected by dementia. And these rights are enshrined in the Equality Act, mental capacity legislation, healthcare legislation and international human rights law. So I'm just going to read the statement. We have the right to an early and accurate diagnosis and to receive evidence-based, appropriate, compassionate and properly funded care and treatment from trained people who understand us and how dementia affects us. This must meet our needs wherever we live. The we statement is paramount to our care delivery in the acute setting and how we must integrate this into our everyday care delivery. We're just going to have a look at some prevalence of hospital admissions for patients living with dementia in England. The number of people being admitted to hospital with dementia increased by 93% from 210,000 2010-11 to 405,000 2017-18. And the number of hospital bed days for people living with dementia increased from 6.3 million 2010-11 to 9.4 million 2017-18. And stays in hospital due to dementia rose 180% from 345,000 to 975,000. And in 2017, people with dementia had a significantly higher proportion of emergency admissions, so 77%, compared to those without 34%. For patients with dementia, 90% of the total costs for the NHS are in emergency admissions, and this is compared to 60% for patients without dementia. So as you can see, with increased admissions to acute settings and how the demand for an acute Admiral nurse with specialist knowledge in dementia is fundamental to best practice in dementia care. We're going to have a look at more local figures from the University Hospitals of Leicester. So UHL is one of the biggest and busiest emergency departments in England, and it serves a large, diverse population across the county and surrounding areas, Leicester, Leicestershire and Rutland. 1.2 million patients approximately visit each year and are cared for within the UHL. And the UHL is across 3 hospital sites, the LRI, the Leicester Royal Infirmary, which has the main emergency department, the Leicester General Hospital, which is elective and rehab sites and outpatient areas, and the Glenfield Hospital, which is a specialist hospital with specialist cardiac and respiratory hospital. And we have approximately 2,000 beds across the 3 sites, with the LRI being the largest bed base. The demographics of Leicestershire, Leicester and Rutland. The LLR, we are awaiting new figures, but currently from the last figures released from 2019, there was 9,204 people with over 65 were diagnosed with dementia. And although we estimate that 12,507 are living with dementia across the LLR. The UHL has 2 acute Admiral nurses, and that's currently out of 34 trusts and growing, offering support to patients living with dementia. The WELL pathway for dementia. A key element of the dementia care pathway is delivery of high quality, evidence-based recommendations in each phase of the WELL pathway, preventing well, diagnosing well, supporting well, living well, and dying well. The best practice in dementia care should be person-centered, individual needs and wishes of the person living with dementia, involving carers. This covers multiple elements of the pathway, and the acute setting supports and implements the pathway during the patient's journey. The UHL has an adaptive version of the WELL pathway to ensure all recommendations are met in line with local and national guidance and legislation. So the acute Admiral nurse. The service was established in 2019 and it consists of 2 nurses. So the admission routes that an acute Admiral nurse would see is elective, which is a planned admission. Then we have the emergency route via the emergency department. And that could be via a 999 call, a GP referral, a community hospital referral, a 111 referral, or the patient may present themselves in A&E. And the UHL Admiral nurse support both elective and emergency admissions into the organisation. However, the acute Admiral nurse mainly supports with emergency admissions. As previously said, established service within the UHL. We do have an easy and simple referral to UHL Admiral nurses to give staff ease to refer into the service. We have easy access to resource via our internal web pages, and all staff can access that 24 hours a day, and information on referral and accessing resources, signposting and policies. So the Admiral nurse can be contacted via telephone, mailbox or in person. And we support around carers support as part of our referral criteria, carer support, stress and fatigue particularly, sharing best practice in dementia care, change in presentation, so changes in the person's living with dementia's journey, transition of care, increased needs now requiring support or new discharge destination to meet new needs, and clinical advice and management to the multidisciplinary team or MDT. We also support with frequency admissions, so high attendance to emergency department with frequent inpatient stays. We also support staff with best practice, and we also support with crisis calls from families, particularly when patients are admitted into the trust. We also have a long-term clinic to follow up carers via telephone to offer support for selected patients. And Admiral nurses also support within the organisation. We support with individual teaching sessions for our champions of older people and dementia. We all teach mandatory dementia training for all new starters. And we also support with strategic and clinical governance and audits. So acute Admiral nurse key interventions. So we support around interventions with nutrition, we support with meal planners, finger foods and our snack menu, which is specifically developed for patients living with dementia, and we support around best practice and mouth care. We also support with psychosocial support for families, with education, emotional support, practical advice, and promoting the Carers Charter. We're supporting clinical team with decision making, so that could be around end stages of dementia, supporting to recognise and then support appropriately. This could involve discussions around advanced care planning, best interest decisions, and clinical advice and management. We also have interventions with risk assessment, so it could be around safeguarding, enhanced falls risk, continence, pain, and that could also involve delirium and cognition screening. Supporting best practice, refer to specialist teams, also identifying patients living with dementia within our organisation, spiritual and religious needs. And then discharge, enabling carers to be involved within the patient's discharge journey, support with capacity and decision making, and supporting the discharge process. This is an example of a case study of a patient's admission to discharge. So this case study is Mr. A. Admission background: Mr. A is a 78-year-old male. He was admitted to Leicester Royal Infirmary. He had a fall at home. It resulted in a fracture of his right hip. A recent antibiotics for a chest infection at home, and he had a past medical history of hypertension, osteoarthritis, and vascular dementia. And social background: he lives in his own home with no package of care and supported by his wife, and is supported by his daughter with shopping and cleaning. And they also, him and his wife visit a memory cafe once a week locally. So the admission to the emergency department, so the arrival to the acute setting. Mr. A arrives in the emergency department with his wife, Mrs. A. It's confirmed that it's a fracture of the right noth or hip fracture. Admission and clerking by medical team and nursing team is completed. All needs are attended to and orientated to the acute setting. And then Mr. A is transferred to a specialist ward to await surgery and commence his inpatient journey. During his time in the emergency department, he had assessment and intervention. And this was an assessment by the frailty team, who are a specialist team in the emergency department. And they'll see patients that are over 65 with a high clinical frailty score, and they're there to support with clinical management and also around prevented admissions. It was also seen by the emergency floor meaningful activity facilitator, and that really gave patient-centered support for him and his wife, and a patient profile began to be completed to support his individual needs. He was also identification of a patient living with dementia and added to the relevant systems, so all staff are aware that this gentleman is living with dementia and requires additional support. And it was also seen by an orthogeriatrician to provide support with complex management of a hip fracture. So the patient's journey transfer to the orthopaedic ward. So Mr. A is then transferred onto a specialist ward. His right neck of femur or right hip fracture was repaired in theatre that evening. Post-operatively, he had a delirium. And I'm just going to define delirium so you're aware of that term. So delirium is sometimes called an acute confusional state, and it is common clinical syndrome characterized by disturbed consciousness, a cognitive function or perception, which has an acute onset and fluctuating course. And it usually develops over 1 to 2 days, and it is a serious condition that is associated with poor outcomes. And patients living with dementia and with a hip fracture are at more risk of an increased presentation of delirium. And at that point, the meaningful activity facilitator supported on the ward implemented support and also made a referral for the Admiral nurse and identified the Admiral nurse to support with carer support, a change in presentation, a transition of care, and sharing best practice in dementia care. And the Admiral nurse intervention. So, how did the Admiral nurse support the inpatient? So, we support around cognitive stimulation and social engagement alongside the meaningful activities team, multidisciplinary working, advocacy for the patient and the carer, emotional support, maintaining independence, nutritional plans, and clinical advice and management. And we're just going to have a closer look around the detail around the Admiral nurse interventions as part of the holistic assessment. So, an holistic nursing assessment was completed for Mr. A, and we supported him to put his glasses on, his hearing aids in place to help with orientation. And this supported Mr. A to be aware of his surroundings, and it really helped for him to engage in conversation. And this is one of the key things that we like to support with, particularly in patients that have a delirium. And Mr. A's nutritional needs were not being met. This was due to Mr. A not wanting to eat or drink due to his delirium, and this was contributing to poor oral intake. A meal planner was implemented. So this is a way of ensuring that Mr. A gets the meals that he likes and enjoys, and that's a way of the catering department knowing which meals to order for him. And so if he can't communicate that effectively, that he will get foods that he does enjoy. And we also have a specific snacks and finger foods menu, which also supports to improve intake and support appetite. His bowels weren't open for 48 hours, and this had increased some of his agitation over this period. And during his assessment, pain was noted on movement and pain assessment was completed. Using the cannot verbally express pain tool or pain aid, Mr. A was score was a 5, indicating he needed his analgesia to be reviewed following hip surgery. And discussion with a meaningful activity facilitator service to support Mr. A with cognitive stimulation and nutritional intake. Contact was made with his wife as she was unable to visit daily due to travelling distance and she does not drive. And she welcomed the calls from the Admiral nurse, and she also felt a lot of support from being able to ring the Admiral nurse to ask questions and follow up. And Mr. A copes well at home, although he does struggle with his memory. The behaviour described was out of character for Mr. A, so written and verbal information was given to the wife and daughter to explain the delirium, and as this was causing a lot of distress on visiting the ward. And a patient profile was completed and supported patient-centred care to improve engagement. And Mr. A was discussed and reviewed by the medical team very promptly, and analgesia and treatment for constipation was started. So we're going to have a look at the next part of the patient's journey, which is discharge. So discharge starts admission and planning and needs are being assessed daily the whole time you're within the acute setting. So discharge options can be a discharge back to the place of residence or your own home, discharge with additional support. That might mean a package of care or equipment that you may require at home to help support you. And also discharge to assess, or D to A pathway, it can be commonly known as. And those is 3 ways. So that could be intermediate care and re-enablement services in your own home, to residential care within the independent and community sector. So it could be a residential care home for a short period, or to a nursing care home within the independent sector. So discharge to different place of residence. It also could be a community hospital where you could go for rehab before going home. So if part of discharge planning, Mr. A was now medically optimised. His delirium had started to really resolve, and he was starting to be his more of his pre-admission self. His increased needs were identified within the multidisciplinary team and the discharge team and the therapy team. and this was discussed with his wife to get her perspective and needs. The Admiral nurse also supported with the wife and discussing things with the multidisciplinary team. And along with the discharge team, it was the suggestion of 4 times a day care package at home for a short period and review, and community therapy referral to follow up within the community. The discharge team accessed a 4 times a day care package, and that was sourced and discharged back to his own home. And transfer occurred back to his own home with a package of care. And the Admiral nurse followed up on discharge and gave a call to the family. And this call is really important. We ring after a few days of discharge, and any questions that the family may have, we can address that at that time. So we'd just like to share some feedback on the impact of an acute Admiral nurse and what that can have during an acute admission. So when talking about my mother and myself, I felt the Admiral nurse was well informed and caring, and I felt confident that if there was a crisis, she'd be able to help. I had no idea about dementia, and it terrified me. And without knowing this help was available, I probably wouldn't have coped. I had no family support. So this feedback really captures how the acute Admiral nurse can influence at a difficult time in anyone's life when they're coming in as an acute admission. I've just got some further reading and some of the resources that have been used as part of the presentation. And I'd just like to thank you all for listening, and I really hope this has given you some insight into the acute Admiral nurse. Thank you for listening, and if you've got any questions,